Okay, let's unpack this. When the average person hears hernia, their mind usually jumps straight to the front.
Right. Groin, belly button, maybe. That's the classic picture.
Exactly. Places where you kind of expect a weakness. But today, we're diving into something a bit different, a hernia that actually targets the back. It's fascinating because it seems counterintuitive. We're talking about the lumbar hernia.
It really is a fascinating area. The posterior abdominal wall, the back, it's built for strength. You've got the spine, the ribs anchoring above, the pelvis below.
Like a natural corset, almost.
Precisely. It's designed to be incredibly robust. But even in this fortress, there are these specific sort of built-in weak spots, areas where tissue can, over time, push its way out.
And that compromises the core issue here. So let's start with the basics. A hernia, any hernia, is just tissue poking through where it shouldn't be, right? Through a layer that's meant to hold it in.
That's the fundamental definition, yes.
But the lumbar hernia, it's technically sometimes called a primary ventral hernia, but it's weird because it's coming out the side back, the dorsolateral aspect, and you said it's rare because of that posterior strength.
Exactly right. It's much less common than, say, an inguinal hernia. Think about the abdominal muscles. Up front, you have the strong rectus muscles, those six-pack muscles.
Yeah.
And wrapping around the sides and back, you have these layers, the obliques, the transversus abdominis. They overlap like plywood for strength.
A layered defense system.
Right. But where these muscle layers meet, or where they attach to bone, you can get these small natural gaps. And there are two specific spots in the lumbar region, these posterior triangles, that are basically missing some muscle reinforcement. They are the inherent weak points.
So it's less like a big crack in the wall, more like a seam that wasn't fully stitched, a planned weakness almost that can fail under pressure.
That's a pretty good analogy, yeah.
Yeah.
Structural compromise.
So for everyone listening, our mission today is to really map out these hidden weak spots, understand why they're so tricky to diagnose. Apparently they can look like other sometimes serious things.
Oh, definitely.
And then explore how modern surgery actually goes about fixing them, keeping everything contained.
Sounds good. And the place to start, absolutely, is the anatomy. Understanding the geography of these triangles is key.
Right, the two anatomical triangles of weakness. That's where these primary lumbar hernias emerge. Let's start with the lower one, the more common site. That's Petit's triangle.
Yes, the inferior lumbar triangle, or Petit's triangle. It's the most frequent location for these primary hernias.
Okay, so where exactly is Petit's? Can you help us visualize it?
Sure. Imagine placing your hand on the top ridge of your hip bone. That's the iliac crest. That forms the bottom border.
Got it, hip bone.
Then medially, towards your spine, you have the edge of that big back muscle, the latissimus dorsi.
Okay.
And then laterally, running sort of towards your front and side, is the border of the external oblique muscle.
So it's this little triangle framed by the hip bone below, the latissimus behind, and the external oblique in front.
Exactly. It's a space where those powerful structures just don't overlap fully. There's less muscle coverage right there.
And it's kind of amazing what can squeeze through that relatively small gap. The source material mentioned seeing cases on scans where it wasn't just fat.
No, not at all. You can get a full peritoneal sac pushing through Petit's. And inside that sac, well, the figure you're likely thinking of showed the caecum, the start of the large intestine, the appendix, even loops of small bowel.
Wow, so it can be a really significant breach, not just a little bulge.
Absolutely. It carries real risks if bowel gets trapped. Now, contrast that with the other site, the superior lumbar triangle, or Grinfeld's triangle.
Grinfeld's, okay, that one's less common, you said, and higher up.
Yes, less common for primary hernias and definitely higher. Its boundaries are different, too.
Right. So what defines Grinfeld's?
Okay, so the top border is the 12th rib, that lowest floating rib. Medially, you have the edge of the sacrospinalis muscles.
Right.
Those thick muscles running right alongside the spine.
Right.
And then laterally, it's bounded by the back edge of the internal oblique muscle this time.
Internal oblique. Got it. So 12th rib, spinal muscles, internal oblique. And these tend to be smaller.
Often, yes. Because of where it's located, kind of tucked up under the rib cage, and maybe because the defect itself is sometimes smaller or tighter, they frequently contain just extra peritoneal fat, the fat that sits behind the abdominal lining.
Which would make them harder to find just by feeling, I imagine.
Much harder. A small, fatty lump high up on the flank. It's subtle. Often, these are only clearly identified on imaging, like a CT scan. You'll see it poking out just below that 12th rib.
So Petit's below, Grinfeld's above. But the underlying reason is the same for both, just not enough muscle in that specific spot.
That's the essence of it for primary hernias. It's an inherent anatomical weakness. Constant pressure from inside the abdomen eventually pushes things out through that path of least resistance.
It's a long-term pressure game.
Exactly. Which brings us to the natural history. What happens if you just leave them alone?
Right. Do they just stay small or?
Unfortunately, no. Like most hernias, the overwhelming tendency is for them to slowly, steadily get bigger over time. The defect doesn't fix itself. The internal pressure continues.
Gravity probably doesn't help either.
Gravity plays a role. Absolutely. So because they enlarge and because of the potential for complications, the general recommendation is usually surgery, elective repair.
Not like some small inguinal hernias where watchful waiting might be an option.
Generally less so for lumbar hernias. The risk of them becoming problematic, large, painful, or worse, incarcerated or strangulated, means fixing them proactively is usually advised.
Okay. Incarcerated means stuck, and strangulated means the blood supply is cut off.
Precisely. Strangulation is a surgical emergency.
Yeah.
If it's just fat poking through, the main symptom might be a dull ache or localized pain. But once a peritoneal sac forms and bowel gets involved.
Then you're worried about obstruction or that emergency scenario.
Exactly. But before we even get to surgery, there's a big hurdle. Actually diagnosing it correctly. The differential diagnosis is really challenging here.
Why is it so easy to miss or misdiagnose?
Couple of reasons. One, the location is just weird. People don't expect a hernia there. Second, the neck of the hernia, the opening, can sometimes be quite narrow or tight.
Ah, so you might not get that classic bulge when someone coughs, the cough impulse.
You might not, or it might be very subtle, which makes it harder to distinguish from other things that cause lumps in that flank or lower back area. Diagnostic errors are, frankly, pretty common.
Okay, so if a patient comes in with a lump back there, what are the main things a doctor needs to rule out before landing on lumbar hernia?
Well, the most common benign thing is a lipoma. Just a simple fatty lump under the skin. Feels soft, maybe a bit doughy.
Similar to a fat-filled hernia, I guess?
Very similar in palpation. Then you have to think about more serious things. An abscess is a big one, especially a cold abscess, maybe from tuberculosis. That tracks down and points in that area.
Right, an infection causing a collection.
Or even though it's rare, an aneurysm. If the lump feels like it's pulsing, you have to consider something like a gluteal artery aneurysm extending up.
Okay, so lipoma, abscess, aneurysm, quite a range.
Definitely. And then there's a huge distinction we have to make, especially if the patient has had surgery in that area before.
Ah, right. The difference between a primary lumbar hernia, one that just developed, and one caused by surgery?
Exactly. An incisional lumbar hernia, also called a secondary lumbar hernia. If someone had, say, kidney surgery through a flank incision years ago, and now they have a bulge, that's likely incisional.
Okay, that seems straightforward enough to trace back. But
Yeah.
you mentioned another one, the imposter.
Yes. The ultimate diagnostic curveball.
Okay.
The lumbar pseudohernia.
Pseudohernia. Okay, the name implies it's not a real hernia defect.
That's exactly right. In a pseudohernia, the actual fascial layer, the strong connective tissue wall, is intact. There's no hole.
So what's causing the bulge then?
It's muscle failure, specifically muscle atrophy. The muscles in that part of the abdominal wall have become weak, thin, and floppy because their nerve supply has been damaged.
Ah, okay, so the wall itself is still there, but it's lost its tone, its tension. Like a trampoline where the fabric is fine, but the springs are broken.
Perfect analogy. The muscles aren't getting the signal to stay taut, so the wall just bulges outward under normal abdominal pressure. It's a functional failure, not a structural hole.
And what typically causes that nerve damage?
Most commonly, it's an injury during a previous surgery in that region. A flank incision for kidney surgery is the classic example. The subcostal nerve, or maybe the ilioinguinal or iliohypogastric nerves, can get stretched, trapped in scar tissue, or even accidentally cut.
So that nerve is like the power cord for those muscles. Cut the power, the muscle weakens and stretches out over time.
Precisely. It's denervation atrophy. And this distinction between a true incisional hernia, a hole, and a pseudohernia, a floppy wall, is critical for planning the repair.
Why does it change the surgery so drastically?
Because you fix them differently. If it's a true hole, a fascial defect, the goal is to close that hole, usually reinforcing it with mesh, standard hernia repair.
Okay.
But if it's a pseudohernia, just putting mesh over that stretched out, weak muscle won't solve the underlying problem. The wall will still bulge.
So what do you do for the pseudohernia then?
You typically need to do something called plication.
Plication.
Yeah, it basically means folding or tucking the stretched, floppy muscle and fascia onto itself, like making a pleat in fabric to tighten it up. You physically shorten that weakened layer to restore some tension. Then you usually reinforce it with mesh.
So it's more of a reconstruction of the wall's tension, not just patching a hole.
Exactly. It's a fundamentally different surgical goal and technique.
Yeah.
Trying to patch a pseudo hernia like a simple hole is likely to fail.
Which really underlines the importance of getting the diagnosis right beforehand. Imaging must be key there.
Absolutely.
Yeah.
CT scanning is invaluable for sorting this out preoperatively. Okay, stepping back, whether it's primary, incisional, or even pseudohernia needing location, given that they tend to get worse, surgery is generally the way forward.
Right. So what are the surgical options?
Well, the core principle is tension-free repair. Trying to just sew the edges of these defects together often puts too much tension on the tissue, especially if the gap is large or the tissue is stiff. That leads to repairs failing.
So mesh is pretty much standard.
Almost always recommended, yes. Synthetic mesh bridges the gap without tension, and you can do the repair either through an open incision or laparoscopically.
Open repair, that's the traditional way. Cut down directly over the hernia.
Yes, you make an incision, dissect down to the hernia sac, push the contents back inside the abdomen, and then repair the defect, usually reinforcing with mesh. The mesh can be placed on top of the muscle layer, on skull or lay, or preferably deep to it, sublay or peritoneal.
Okay. And the laparoscopic approach, you mentioned TAPP.
All right, TAPP stands for transabdominal preperitoneal repair. This has become really popular, especially for the primary lumbar hernias and even some smaller incisional ones.
How does that work? You're fixing a hernia in the back by going through the front.
It sounds counterintuitive, but yes. The surgeon uses the abdominal cavity itself as the route to get to the back wall from the inside.
Okay, walk me through that.
So the patient is usually positioned on their side, or partially on their side, semilateral position. The surgeon makes small incisions on the abdomen, well away from the hernia itself, and inserts a camera and instruments.
Standard laparoscopic setup.
Exactly. Then, once inside the abdomen, they find the area of the hernia from the inside. The key step in TAPP is that they carefully cut open the peritoneum, the thin lining of the abdominal cavity, over the area of the defect.
Ah, creating a flap of that lining.
Precisely. They peel back that peritoneal flap to expose the space behind the peritoneum, but in front of the muscle defect. This is the preperitoneal or extraperitoneal space.
So they're creating their workspace between the inner lining and the actual weak spot in the wall.
You got it. This gives them a fantastic view of the defect from the inside. They can clearly see the edges of the hole, reduce any contents, often it's that extraperitoneal fat we mentioned, and assess the quality of the surrounding tissue.
And then the mesh goes in.
Yes. A large piece of mesh is placed into that extraperitoneal space, covering the defect entirely. And the sources really emphasize the need for ample overlap.
Meaning the mesh needs to extend well beyond the edges of the actual hole?
Absolutely. Several centimeters of overlap onto the strong, healthy fascia all around the defect. This wide footprint is crucial to prevent the hernia from just finding a way around the edge of the mesh later on. It distributes the pressure.
Makes sense. Secure anchoring.
Then once the mesh is positioned and usually fixed in place, they close that peritoneal flap back over the mesh, usually with sutures or tacks.
Sealing the mesh off from the inside of the abdomen.
Exactly. This is a key advantage. It keeps the mesh out of direct contact with the bowel, which significantly reduces the risk of adhesions or, rarely, erosion of the mesh into the bowel later on.
So TAPP offers good visualization, deep mesh placement, wide overlap, and keeps the mesh away from the bowel. Seems like a lot of advantages for the right kind of lumbar hernia.
It does, yeah. For primary and smaller defects, it's often preferred due to potentially less pain and quicker recovery compared to a large open incision.
Okay, this is where things get really interesting, right? Moving into the modern tools and advancements that help tackle these, especially the more complex ones.
Definitely. And perhaps the single biggest game changer, particularly for those tricky incisional or traumatic lumbar hernias, has been the routine use of high-quality cross-sectional imaging, CT scans primarily.
Why is CT so critical now, more than just confirming there's a bulge?
Oh, much more, because, as we discussed, just feeling the lump can be incredibly misleading. A CT scan gives you that detailed anatomical map before you operate.
What specific details does it show?
It shows you exactly which layers are involved. Is the fascia torn? Which muscles are intact, which are thin or damaged? And critically, it helps differentiate a true hole, an incisional hernia, from that generalized bulge of muscle atrophy you see in a pseudohernia.
So it can actually see the nerve damage effect on the muscle.
It shows the results of nerve damage, the thinning, the fatty infiltration of the muscle. It turns that ambiguous lump into a defined structural or functional problem. You can see the size and number of defects, the quality of the surrounding tissue. It's essentially the blueprint for the repair.
Crucial for planning, especially if you suspect it's complex, like needing that flickication for a pseudohernia.
Absolutely. You need to know what you're getting into, what size mesh you'll need, whether you might need more advanced reconstructive techniques. CT provides that roadmap.
Okay, let's talk about the mesh itself. You said synthetic mesh is standard, but have the meshes themselves improved?
Dramatically. There's been a big shift in mesh technology across all hernia surgery. The trend now is strongly towards synthetic meshes that are lightweight and have large pores, usually made of polypropylene.
Lightweight and large pore. Why large pores? Wouldn't tiny pores make it stronger, less likely for things to poke through?
It seems logical, but actually the opposite turned out to be true in terms of long-term outcomes. The early meshes were often heavyweight and had very small pores,
Right.
and they provoke a really intense foreign body reaction, lots of inflammation, and dense scar tissue formation.
Okay.
This dense scar tissue would then contract significantly over time. The mesh could literally shrink, sometimes by 50% or more.
Wow, that sounds bad.
It was. This shrinkage led to stiffness, a feeling of a hard plate in the body, chronic pain for many patients, and paradoxically, it could even cause the hernia to recur because the mesh pulled away from its fixation points as it contracted.
So the large pores are designed to prevent that massive scarring and contraction.
Exactly. Large pores, usually defining pores bigger than about 1 or 1.5 millimeters, allow for better tissue integration. You still get collagen growing into the mesh, which is what gives the repair its strength. But it's a more organized, flexible collagen, more like a pliable scaffold than a rigid plate.
So less scar, less shrinkage, less chronic pain, more flexibility.
That's the goal. A strong but elastic repair that moves more naturally with the body's tissues. And that mesh works best when it's placed deep.
Right, you mentioned the sublay or extraperitoneal placement like in the TAPP repair. Why is deep better?
There's a mechanical advantage. Think about the pressure inside your abdomen, intra-abdominal pressure. Every time you breathe, cough, strain, that pressure pushes outwards.
Okay.
If the mesh is placed deep behind the muscle defect, that internal pressure actually helps to push the mesh flat against the abdominal wall, holding it in place. It uses physics to its advantage.
Like the pressure is pinning the patch against the hole from the inside.
Precisely. But if you put the mesh on the outside only, that same internal pressure is constantly trying to push the hernia contents past the mesh, trying to blow it off the wall. It's working against the repair.
That makes total sense. Plus, putting it on top probably involves more dissection of the skin and fat layers.
It often does, yeah. You might need to create large skin flaps to get enough overlap with an onlay mesh, which increases the risk of things like fluid collections, seromas, or wound healing problems in the flank. Deep placement is generally preferred structurally and biologically.
Okay, so better imaging, better mesh, better placement techniques. But what about those really tough cases? The complex incisional hernias, maybe with that pseudohernia component from nerve damage?
Yeah, those remain a significant challenge. They are definitely harder to fix successfully than a straightforward primary Petit's hernia.
What makes them so much harder?
You're often dealing with multiple problems at once. A potentially large defect, a lot of scar tissue from previous surgeries, maybe poor tissue quality overall, and that underlying muscle weakness from denervation if it's a pseudohernia situation.
The trifecta you mentioned earlier.
Right, so the goal shifts from just repair to reconstruction. You're trying to rebuild that portion of the abdominal wall, restore its function as much as possible, not just plug a hole.
And that's where the polequication comes back in for the pseudohernias.
Exactly. If the CT scan confirms significant muscle atrophy and bulging due to nerve damage, the operation will likely involve placating, folding, and tightening that stretched out fascial layer to provide some inherent tension and support, in addition to reinforcing it all with mesh.
Trying to rebuild the trampoline's tension even with broken springs.
That's a good way to think about it. You're using the remaining structure, tightening it up, and then adding the mesh scaffold for long-term support.
But it sounds like even with the best reconstruction, if there's permanent nerve damage, the result might not be perfect.
That's a really important point for managing patient expectations. If the nerve supply to those muscles is permanently gone, you might achieve a stable contained repair, but some degree of bulging or asymmetry might persist. You can reinforce the wall, but you can't magically make denervated muscle contract normally again.
So the goal is containment, function, and pain relief, not necessarily a perfectly flat cosmetic result in those complex cases.
Exactly. It's about achieving the best possible outcome given the underlying pathology, which again highlights why that preoperative CT planning is so vital. It helps the surgeon understand the limitations and set realistic goals with the patient.
Okay, let's try and synthesize this. Lumbar hernias, rare, kind of sneaky protrusions through the back wall.
Right, through those natural weak spots, Petit's triangle down low or Grinfeld's triangle up high, hidden weaknesses in the body's natural fortress.
Defined by that lack of muscle support, and they can contain just fat or, more seriously, bowel.
Making diagnosis tricky. They look like other lumps, lipomas, abscesses. And crucially, you have to differentiate them from incisional hernias, and especially that pseudohernia caused by nerve damage.
Because that difference changes the whole surgical game plan.
Completely.
And because they tend to grow and can get complicated, surgery is usually the recommended path.
Yes, aiming for a tension-free repair. That almost always means using modern synthetic large pore mesh.
Placed deep, ideally in that extraperitoneal space, often using the laparoscopic TAPP technique for the best visualization and mechanical advantage.
Exactly. Deep placement uses the body's own pressure to help secure the mesh and keeps it away from the bowel. And CT scans are essential beforehand, especially for complex cases, to map everything out.
It seems like understanding lumbar hernias really forces you to appreciate the trade-offs in our anatomy.
How so?
Well, the back needs to be incredibly strong, right?
Right.
Protecting the spine and organs, at priority one. But we also need to twist, bend, move. So the muscles can't just be one solid sheet of armor. They have to be layered, allow movement, attach in complex ways.
Which inevitably creates those junctions, those intersections,
Mm.
those small gaps, like Petit's and Grinfeld's.
Exactly. They're like necessary structural compromises to allow for flexibility. And sometimes those compromises are just enough of a weak point.
For the constant pressure inside to find a way out.
Yeah. So the final thought to leave everyone with is maybe this. Lumbar hernias are a perfect example of how, even in the strongest biological designs, the relentless everyday pressures of just living, breathing, moving gravity will always seek out and test the smallest inherent weakness. Anatomy is brilliant, but it's always fundamentally a compromise.